ask how many of you have heard of Coordinate My Care? And how many of you have heard of 111? So a few more. Okay, well, what I'm going to do is I'm going to tell you, give you a very brief overview of Coordinate My Care, and then Gerard is going to give you a demonstration of how it actually works in practice. And it's a great pleasure for me to be back here because I started my career in practice of medicine at Meadow House, where I worked for 3 years. And so this area has always been close to my heart, and I've always watched what you've done to develop your palliative care services. And I hope that Coordinate My Care will come back to show you that it's actually just another step in building off the services that you already have here. So our journey of Coordinate My Care started in 2007, when in the Royal Marsden Hospital we had 752 deaths. And my chief executive called me in and she said, Judah, we've had so many deaths in the hospital, people are dying here, yet they all tell us they want to die at home, we've got to do something. And so to that end we copied a model of care from Australia, from Sydney, and we called it hospital to home. And essentially what it was, and is when a patient has no more radiotherapy, surgery or chemotherapy options, they are referred to the hospital to home nurse, who does a comprehensive care plan. And for the first time, often for these patients, the patient is asked, what do you want? And that is actually how we've built Coordinate My Care. What does the patient want? So the patient is the central focus, and then around that we put a care plan, an advanced care plan, resuscitation orders, contacts, and then obviously outcomes. And then we fax that to, after we've had this meeting, we fax it to the GP, the out-of-hours GP, the London Ambulance Service, the district nurses, and the palliative care services. And as you can imagine, faxing to a minimum of 5 numbers is very time-consuming. And the next day, if the patient changes their mind, or clinically the picture has changed, we've got to start all over again. But even with the faxing model, we managed to change where patients died, and we managed to allow patients to die how they wished to and where they wished to. And last year in the Royal Marsden Hospital, we had 251 deaths, in spite of the fact that when we started, we had 30,000 referrals to the Marsden, and last year we had close to 40,000. So the model works. So we then went to see the Department of Health and said, would they help us and support us in doing this electronically, because it would be so much easier if it was electronic. And to that end, they said, they put it in the end-of-life care strategy for 2008, and they put out a call for pilots, and we applied. And we got Merton and Sutton one on your slide, and another one was appointed in London, which was Camden and Islington. And we both put in our pilots that we would reflect the practice in the local area, we would make it electronic, and we would, at the end of it, recommend a pan-London solution. Halfway through the pilot, it became apparent that 3 other groups had set up what were termed end-of-life care registers, electronic end-of-life care registers. So the ambulance service got us together and said, look, this is a nonsense. We remember in 1972 when we had 9 ambulance services for London, it's a nonsense. We've got to have one system. So we all got together and we agreed we would have one system. And we went out to GPs, district nurses, patients, relatives, and said, what would you like us to call it? And there was an overwhelming, clear steer for us. Don't call it a register because of the paedophile issues, and don't call it death or dying because some people don't want to know they're dying or when they're going to be dead. So we said, well, what does it do? And it is coordination of care. It does what it says on the tin. And we wanted the patient in the middle, so it's coordinating my care. And in 2010, we called it Coordinate My Care. And thus we began. And so what is it? It's an electronic solution which underpins a clinical service. And the clinical service is all of you who provide the service for the people of Ealing. And all patients that come into the pathway when they are ill and they know they have a limited life expectancy will come into the pathway through different ways. Their first time they may come into the pathway may be the district nurse, it may be the hospital, it may be the A&E, it may be any one of us, and we all for these patients. We can no longer think of patients' care by one GP like we used to do. 2/3 of the week is out of hours. And as your chair lady said to me earlier, patients don't die in hours. So this is a service to connect you all to the care for patients 24/7. It has a patient portal, and the patient will be able to look in and see their own care record by the tail end of 2013. Currently, they can get a hard copy, and the reason we haven't let them look in is we want to roll it out for the whole of London first, get all the feedback from you, the professionals, and then when we've tweaked it to be a smooth and seamless service, we will then open a portal to patients. So what does it look like? Every patient consents prospectively to have a record. There is no patient that has not consented that gets a record, except in patients who lack capacity. And then you as the professionals make that decision on their behalf. And it opens up the page, you get demographics, current care plan, advanced care plan, treatment escalation plan, medications, and so on, and Gerard will take you through that. So I'm going to give you two very quick stories to show you how this is working. Fred lived in a care home in a borough next to yours. He had a CMC record and he made it very clear he wanted to die in a hospice. And one night he fell out of bed unexpectedly. The carers could not lift him back to bed. They called 999. The minute you put a patient onto the record, create a record, it emails a record to the London Ambulance Service 111 and your out-of-hours service provider. And so they all know, it flashes up to say this is a CMC patient. So the London Ambulance knew he wanted to die in hospice. They actually phoned the hospice and said, should the need be there, do you have a bed? And they said yes. And so they went out, but when they got there, he lacerated his forehead. So they took him in the ambulance, took him via A&E, and when he had been stitched up, they dropped him off in the hospice. He avoided an unnecessary admission to A&E through the medical advice, up to a medical ward, and he died peacefully 3 days later in the bed that had been made nice and comfortable for him in a hospice. Jane was a patient at the Royal Marsden. She has lung cancer, and one of my consultant colleagues created a record for her. We knew she was going to have hemoptysis. She had a large tumour that was bleeding. We discussed this with her. It was in her treatment escalation plan what to do. And in her care plan, her son knew, should there be a problem, to call the GP. He called the GP, it went through to the out-of-hours. And the out-of-hours GP, as per her care plan, came out. The out-of-hours GP was a locum, and she panicked, and she phoned 999 saying he was coughing blood. 999 knew it was a CMC patient. They arrived. They calmed the situation down. They discussed CMC with the locum covering the out-of-hours who had not heard of CMC before. And they agreed to go through the care plan as per the CMC record. The district nurse was called. She put up a syringe driver. And the following evening, which was Saturday evening, the patient died at home. So we've got two pathways, which it's almost like having a sat-nav. You know, you go offline and the sat-nav says, no, this is where we planned to go in the first place, let's just go back en route. So it's just really, we've all been using maps and different maps wherever we are, and this just gives us one general sat-nav for us all to use. So this is what it looks like in the cars. We're going live in the cars of your out-of-hours providers. And in one area we're using iPads, and in another area we're using Microsoft, and we will do a compare and contrast to see. So we heard from your out-of-hours GP providers that they wanted to see the record in the cars, and so this is one of our service developments. How does it work with 111? For those of you who are not familiar with 111, 111 is an unscheduled telephone advisory service that operates 24/7. It's for all emergencies that are not 999. So when this call comes in to 111, 111 knows where that call is coming from. From the landline, it can detect which house it's coming from. From the mobile, it knows the GPS coordinates. So it can know that there is a CMC record. Additionally, when you put your patient onto CMC and you put any telephone number down for a contact, those contact numbers are banked, and 111 knows that this is a bank number and therefore has your contact as a CMC patient. So the first thing the 111 call handler will say, is this the patient you're calling about at this address? Because you may have 6 people living at one address, but only one is the patient. If they say yes, they ask 3 questions. Is there massive bleeding, very bad pain, or very bad breathlessness? And if any one of those 3 questions are answered yes, then an ambulance is immediately dispatched. And that does not mean the ambulance will transfer the patient to the hospital. It means that the ambulance will be there because we felt that a person needs to be with our patients in their hour of distress, and not in half an hour, in 8 minutes. And the ambulance will come, and they send a green ambulance in the lane, and the green ambulance is probably 2 paramedics in a car, and they will take them through the CMC care plan and do what you, the professionals, have designed with your patient for best care. If whatever they're calling about is not in the CMC record, and the nurse at 111 will be taking them through this record, he or she will then take the patient or the caller through normal NHS pathways. So for example, if you've got a patient gently dying of CA prostate, suddenly gets left-sided chest pain, and an NHS pathway says that could be a myocardial infarction, that could be a pulmonary embolus, it will go down the pathways to determine best care for a myocardial infarction or a pulmonary embolus. So Coordinate My Care's care plans are very specific, and if it's not on the care plan, it will be redirected through a safe plan. So how are we doing? Well, we work with the Royal Marsden and was commissioned by NHS London to roll this program out and to train 4,500 clinicians over London by April the 1st next year. And the training is not necessarily how to use the system. You know, if you can order a book on Amazon, it's not rocket science to use this. What is very specific and very important is a culture change. This is the first time that we all work together across completely different aspects of a patient's care, and we all need to know how to consent these patients properly. We need to know how to identify properly who is in their last year of life, who is appropriate to go on the record, to get a record. We train you how to have difficult conversations. It is not easy to ask patients about their preferences if you're not comfortable with talking about dying. How do you start the conversation? How do you begin it? How do you end it? And the training acknowledges anticipatory care plans. How do you put care plans in? We've listened in areas we've been to before you and into the treatment escalation. Gerald will show you how we've now put prompts in to show you how to do it. And St. Christopher's, we subcontracted them to roll out the nursing home training as we go along, because 1/3 of patients who go to a nursing home die in the first 3 months. So why not ask patients what they would like on arrival when they get everything else clocked in when they become patients in nursing homes. And so I think it's really very important that changing in culture requires training, and that is what is there. There are packs at the front. In the packs are a single sheet on quick steps of how to log a patient on, how to create a record. So if you forget, very easy, just open it to give you a quick guide. It will give you the SPIC tool, how to identify the patients. It will give you prompts and ideas on how to start these conversations and end them. And it's also got a section on the most commonly asked questions and answers. So there should be enough packs for you all to take one home, so it will all be there if you have any questions. We also have a website. So what are the data? On the first Wednesday of every month, we ask you for a lead clinician and a lead commissioner, and we send you the data. NHS London were of the view we should send you all the data for all the boroughs so you can see, compare and contrast, and it's been wonderful because, for example, Croydon saw how well the nursing homes were doing in Hillingdon, and they've sent people up to Hillingdon to find out what they're doing in nursing homes and to discover it's a fantastic model of care for nursing homes in England. So it's looking at good practice. But in general, these were data, as you can see, till the end of September. October, we've actually got over 3,000 records. But these data are 2,827 records from 6 boroughs in London. 673 patients have died, and 82% have died where they chose to die. We're really pleased at our outcomes. Who is having a record created for them? Currently, only 45% cancer, whereas historically, cancer patients have got the best deal. 55% are non-malignant, and 14% were dementia. And it's very interesting, we're doing a dementia template so we can start asking patients that are becoming demented so they can make their own choices before it's too late to make the choices. And then you'll get in your monthly report where your patients are dying and compare to other places. So as I said to you, we then can share good practice across London. The other thing is the clinician profile. When we first started, the GP said that this was going to be too much work. And, to have these conversations, you can't fit in a 10-minute appointment. But what has become apparent is that if we all chip in a bit, starts in the hospital, starts in the outpatient, starts in general practice, and we all do a little bit, and we add on to the record. This is not a once-off creation of a record. This is a development and a maturation of each person's record, and as you know, it's not appropriate to ask these questions perhaps on the first visit. It may not be on the second visit. But when we're doing visits in the clinics, now in the renal team at Barts in London who created our renal template, they see those patients for dialysis 3 times a week. So they have got lots of time to have these discussions, and they are creating the records for the end-stage renal patients. So it's everybody helping to create the records and enrich them and get really good outcomes. And you can see in Sutton and Merton, which was obviously the first pilot, so we've got more patients and more deaths. 77% of patients have died outside of hospital. That compares to the national data the year before last, when for London, 65% of patients died in hospital. So overall, if you look at the comparative data, these are the Marie Curie data for last year, and so London has improved overall anyway. 59% of Londoners died in hospital. In England it was better, it was 54%. But if you go on a coordinate my care record, you have a 24% chance of dying in hospital, and all the rest are dying out of hospital, which is clearly what our feedback says. This is where our patients want to be, in their homes. Dying is not a medical event. Dying is a social event, it's a spiritual event, it's a family event. It is so important that our patients are part of their family when they die. It's better for them, and we know from research it's much better for the bereaved relatives. So overall, what do we think we've achieved? I haven't got time to go into costings, but if you're going to have value improvement for any service, you need to maintain the quality and decrease the cost. We maintain the costs and increase the quality, but we really believe we've got the Holy Grail. We do believe we have improved the quality and we've decreased the cost by decreasing admission to hospital, decreasing ambulance transfers, and our preliminary data, which we will publish probably in December, has shown very clear evidence of decreased cost to the NHS. So that's all I'm going to say. We are on Google us, and we have a website with DVDs on it, and all the training packs and anything else you wish to ask us. Gerard's going to give you a demonstration, and then we'll answer any questions you would have.